Good morning. Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. According to Section 14 of the bylaws, committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. For the record, Jose Pagan delegated Jackie Rowe Adams as a member for the purpose of quorum and voting for this meeting. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on May 8th, 2023. For the second? Second. Great. And Dr. Katz?
Yes.
Sally Hernandez-Pinheiro?
Yes.
And Jackie Rowe Adams?
Yes.
And I vote yes, so the motion is adopted. Next, we have one action item for consideration. I think Ms. Lisa Hendricks is going to read the resolution into the record and then proceed with the presentation.
I'm Carl Anderson. I'm here in place of Lisa Hendricks. She couldn't make it today.
Thank you.
Good afternoon. For committee consideration, authorizing the New York City Health and Hospitals Corporation, the system, to execute an agreement with Optum Insight, Optum, for contact center services for an initial term of 3 years with two one-year options solely exercisable by the system in an amount not to exceed $145,593,595 for the entire contract term of 5 years. Background and current state, it's common practice for health systems to fully outsource, have a combination of outsource and internal staff, or use internal staff only for centralized patient contact center. Call volume tends to dictate the most efficient and cost-effective approach. With inbound call volume increasing to 2.6 million calls in 2022 and expected annual year-over-year growth, as well as more practices requesting appointment scheduling by the contact center, having a cost-effective and operationally efficient vendor partner to handle overflow calls is critical to serving our patients, practices, and facilities. In January of 2015, Health and Hospitals activated a GPO agreement with Change Healthcare, a 7-year contract term with authority through September 2023. The current fee structure is per minute of agent talk time and transferred calls plus monthly service fee for all service lines and/or services. 2020 to 2023 historically, average annual cost for services across the system was approximately $21 million. Projected average annual cost with all services remaining the same, including dental expansion and a 3% year-over-year increase, is approximately $26.3 million. The scope of this project is to secure a partnership with a vendor that is experienced and knowledgeable with a successful footprint in healthcare. They're using industry-leading technologies, has a robust operational support system, a cost-effective fee structure, and a proven track record. With this RFP, we are looking to add more structure and rigor regarding the vendor's operational performance and meeting performance and quality targets, incorporating technologies that improve patient experience, and a fee structure that is more cost-effective than what we have with our previous contract. An RFP allows us to view current vendors in the marketplace, as well as new technologies and innovations that are being implemented in the contact center BPO industry, and the opportunity to understand and explore improved cost and fee structure. Our RFP development and goals. The scope was developed based on use cases across the system and using current internal and vendor operational performance, current industry standards, and 20 plus years of our contact center's senior leadership experience in this space, serving as both client and vendor. Key scope issues included on-time deliverables, service level agreements, and key performance indicators, reporting, technology platforms, offerings and integration, compatibility, security, and robust operational support. Desired outcome of the RFP: service level agreements that meet responsible budget requirements, performance target penalties, inclusive cost-effective fee structure of per minute or FTE, robust operational support, contact center forecasting and real time, training delivery and instructional quality, instructional design and quality management. Organize all contact center services provided by the vendor under one contact center organization. Vendors typically performing in this space are Optum, Change Healthcare, Teletech, and Teleperformance. There are no anticipated labor impacts or role changes to our internal contact center staff as a result of this RFP. We anticipate additional EITS staff support may be needed should we transition to a new vendor in 2023. Over the course of the next 2 years, our goal is to lessen our dependence on the vendor partner and use our health and hospitals technologies, Cisco platform, Collaborate, etc., for both our internal and outsourced vendor staff. This will create a singular experience for the patient and the agent as they leverage one system for answering, tracking, and managing calls, allow for better control of onboarding and offboarding vendor resources, ensure that vendors' access and systems leverage health and hospital security controls and align with our standards, and allows the contact center to stay current on technology and leverage new features without having to be reliant on the vendor's technology. The RFP criteria: minimum criteria, 10 years in business, footprint in healthcare with proven ability to scale a high volume contact center, annual revenue of $100 million. For MWBE firms, there was no revenue requirement. Substantive criteria included 15% cost, 10% MWBE, 20% technology, 25% operational support, and 30% staffing and scalability. The evaluation included SAVP, Senior Director from the Contact Center, Chief Information Officer, Deputy Corporate Compliance Officer, Director of Unified Comms and VoIP, AVP Patient Access and Revenue Cycle, AED Gotham Health Center Operations, AED Bellevue, and additional SAVP. Overview of procurement timeline. May 2nd, application to issue request for proposals was approved by CRC. May 10th, RFP posted on City Record, sent directly to 6 vendors, including an MWBE prime candidate. May 16th, pre-proposal conference held, 25 vendors attended. June 8th, proposals due, 9 competitive proposals received. June 15th, evaluation committee conducted first round of scoring on proposals submitted, which included an MWBE vendor. Top 3 firms were shortlisted. 620 and 623, all 3 firms conducted virtual presentations and were interviewed by the evaluation committee. And on 626, the evaluation committee debriefed and submitted final scores. Optum Insight, Inc. was the highest rated proposer. Background on Optum. Optum has been in business for over 30 years with a focus in technology and staffing. They've served over 120 million consumers across the country and averaged 300 million support calls annually in healthcare. Some of their clients include AARP, NYU, Arkansas Department of Human Services, Georgia Department of Community Health, Indiana Family and Social Services Administration, Tennessee Healthcare Finance Administrations. Optum had a recent 2-year partnership with NYC Health and Hospitals, providing services and staff for the NYC Test and Trace Contact Center. With the exception of surge events, the Optum team consistently met the monthly targeted trace performance metrics of 95% contact rate of positive cases and close contacts within 24 hours, with a 90% plus rate of reaching the intended party. They also consistently met the call quality metrics, ensuring a positive experience for the 2+ million New Yorkers the team engaged with. Implementation with Optum carries less risk than another vendor. Their acquisition of our incumbent vendor, Change Healthcare, allows for the retention of tenured, high-performing staff and the historical knowledge and familiarity with our technological infrastructure and business lines. The system will not need additional EITS support resources for Optum migration and integration. Optum will enhance services provided by current staff by bringing additional expertise, structure, and rigor to training, quality, workforce management, and operational oversight to drive a higher level of overall performance. They will upgrade the contact center to a more advanced omni-channel technological platform, as well as offer customer satisfaction CSAT surveys and customer effort scores immediately following the patient's interaction with the contact center. Artificial intelligence will be incorporated in services during life of contract, reducing agent call volume and handle time. To begin, Patients with general questions will be able to self-serve quickly, receiving the information needed without speaking with a contact center agent. Optum has a strong partnership with Epic, giving us the ability to explore additional options integration to improve the patient experience and additional cost-saving measures. Optum will commit to a monthly penalty charge to be determined during contract negotiation for failure to meet the contact center's monthly key performance indicators. An example of some of the KPIs include abandon rate, average speed of answer, and overall service level. Bilingual hiring, minimum of 30% staff will be certified bilingual, Spanish speaking, and writing. AI call deflection, minimum percentage to be determined of initial call types that do not include caller authentication or Epic integration. Omnichannel statistics, service level requirements for web chat and email. Meeting the language needs of our patients, in addition to bilingual hiring and staffing targets, Optum will deploy the use of language interpretation services for our contact center team to be able to effectively assist in all languages. Cost structure to be based on a combination of FTE rates and permanent rates of proposed staff and AI call deflection. Call deflection, where applicable with artificial intelligence, will be billed at a significantly lower per minute rate. We anticipate an initial conservative goal of 30% call deflection. Industry standard call deflection rates can be as high as 50 to 60%. MWBE component percentage. Recruiting and staffing, 20%, information systems and automated messaging, 5%, and an implementation, 5%, for a vendor diversity component of 30%. Staffing is likely to represent the majority of diverse vendor opportunity under this solicitation. However, depending upon the proposer's business models and capabilities, there could be additional potential for smaller scopes of work such as technology, applications, and implementation services. After such review and analysis, and consistent with the data reflected in the table above, it has been determined that an MWBE component percentage of 30% is appropriate for this solicitation. This is a summary of MWBE utilization plan for Optum Insight. Includes 3 vendors: Pride Technologies, Unique Corp, and IT Resource Solutions, all for contact call center agents and supervisory staff, for a goal of 36%. So, final request. The Office of Ambulatory Care and Population Health is seeking approval to enter into contract with Optum Insight to provide contact center services at a not to exceed amount of $145,593,595. Anticipated contract start date, October 1st, 2023. The terms of the contract are a 3-year term with 2 one-year renewal options for a total of 5 years.
Great, thank you. Let me open it up for questions. Dr. Katz.
I fully support the contract. As you were presenting it, I was thinking there's value always in having a contact center because there will always be overflow times, weekends and nights when it's hard to staff. But I support what you had said earlier, that you don't want to over-rely on this because the resource in some ways is better done closer to the program, right? And so what I was wondering is how we would assess over the next period of time that we were making the right progress, right? The right progress would not be ending the contract in 3 years, because again, I think that an organization like ours will always have some need for overflow. But how would we assess in 2 years that we had made the progress we wanted to make in taking inside those functions that would better be done by us?
It's a complicated question.
Yeah, good question.
Sure. I think my tenure at the contact center has been about 2 to 3 years, starting with test and trace. And over the last 2 years, our focus has really been on building a more robust technological support system that we use internally and building a training team, a quality team, support staff for scripting, so that all of the knowledge, all of the tribal knowledge, all of the operational process and everything are owned internally. And that's really allows us to better scale internally and be able to make sure that no matter which vendor we have or how much support we use, we don't need their support as much. And then the other part of that is kind of building out our technology and upgrading that, which we've been doing with Calabrio and Cisco.
Yes, what I'd suggest is that, if you follow the old Yogi Berra aphorism that if you don't know where you're going, you don't know when you'll get there. It would be worth sketching out again. It's not for, the contract is good. It's not about the contract. It's about how we would know, right, in 2 years that we made the progress we wanted to make, right? We should be able to stake out now where you want to be in 2 years, 3 years, right? And some of it is the pure technology, right? That calls will go down because, for example, patients are now able to make their own appointments on our Epic system, right? So some of it has nothing to do with us doing the function, right? But you want to see, for a variety of reasons, the call volume decreasing. And I would say also, especially decreasing during the heavy work hours, right? Again, I'm less concerned about, the 3 a.m., Saturday night call, right? That's what you want big organized call systems to do, right? Low volume, they have operators all over the place. That's a great call center stuff. But I'd like to know that over time, more and more of the functions are being done by us. And I think just sketching out, not for the contract presentation, but for our success, what you want it to look like in 1 year, 2 years, 3 years, so that we can all be working toward that goal.
Mitch, is that something that you envision would be doing with current staff, or?
Yeah, right. I mean, it's a question of, my own belief is that most of the functions are better done by us during the work hours. Mm-hmm. And most of the functions are best done by a call center on the not work hours, because you just can't get the right thing. And we've made tremendous progress in call center operations over the last 5 years. I just think there's more progress to go. And again, some of it is just the technology of, if people used to call for an appointment and now they can get it on the web, not everyone will, but right, let's say 20% do, then there should be a corresponding 20% decrease in the calls related to, getting the appointment. And to the extent that some of it, the calls, and you have it in there, that they're going to handle by, what I'll call drop-down menus, right? The person who wants to know what time the lab is open. It's a very common question in the place I work. When is the lab open? Have to know when the lab opens. As it turns out, it is open on Saturday mornings, but it closes early on Wednesday, right? Who could keep that in your head, right? On the other hand, I don't need a real person to answer that question, right? You need easy ability to say lab hours, right, and get the answer. Once you have that answer, I don't need the call. I don't need them to do that, right? I mean, if the technology is a drop down, then I should be able to do that, and I should send them the things that are not. So anyway, I do think we've made a lot of progress, but we should have a forward-looking plan on what a year, 2 years, 3 years looks like.
Absolutely.
Frida, I have a lot of questions. I won't ask them all here because I know we're tight on time. But I guess I start from a place that says I don't know necessarily that calls are better handled in-house, perhaps because I don't have your 5-year view of the progress that we've made. But it would be tremendously helpful to have a review of how our call center has changed, how it operates now, where the gaps are. Uh, I think there's still an issue with getting through on the call center, but uh, it, it may have changed significantly. I don't know that. I'd also like to know whether there are key performance indicators that our in-house staff is required to meet, because I'd like to compare apples and apples and make sure that we're getting the same level of effectiveness as you do with an external operator. Um, I'm a little confused because, in the QAPI book, we see calls answered during the day and the calls after hour, and the calls after hours are always kind of abysmal. And I don't know if it was Change Health that's doing it, or it's somebody else that's doing the answering, or we're doing it. But it's always not a very, it's
You mean percentage answered or?
percentage, 50%, yes. They're generally below 50% of calls answered after hours, which I guess is after 5 and on weekends. So I'd like to better understand who is answering those calls and why the metrics are like that for after hours calls. When you talk about handling overflow calls, is that calls during all hours, 24/7?
Uh, so the calls go to our internal staff first. It looks for an internal staff person, depending on if they're calling for specialty, and then the overflow is it seeks out a vendor agent after that. And in addition, the vendor handles calls that are after hours, like you're stating, like 5 p.m. or later and before 9 a.m. And they handle the calls on the weekends.
So was it Change Health that has been answering the calls
Yes.
after hours?
Yes.
And they're going to continue to be part of this?
They will. Optum has acquired Change Healthcare, and
Right.
so we will. The good part of that is that we'll retain their tribal knowledge. We'll retain their knowledge of our operating structure and the relationships that we have. But Optum will take a much heavier hand and add some structure and rigor that hasn't been there previously, and some technology support that hasn't been there previously. I don't have a lot of time today, I'm sure, to talk about
Right.
our improvements from a service level perspective, but we've been very focused on ensuring that there's somebody there when someone calls to pick up the phone, not just during the day, but also after hours.
Right.
So if you could share, where you're getting that feedback around the after hours timeframe, I'm happy to take that offline. I don't know.
And maybe
That's
I'm
appropriate.
misreading the QAPI
Well,
figures.
we should
but
all go
we'll
back
take
and
a
look at the
it.
QAPI,
Yes,
the QAPI
yes.
report. And Sally, just to clarify what I was saying, people are calling to get information.
Right.
Let's say you're a patient of mine. Your best shot is if you call the medicine clinic, adult 2, because there's a group of staff members who provide support to my practice and the practices there. The further you get away, the less likely you are to have the information to provide the correct answer. So that's why I always believe, it's true, of course, if you have one group of workers who are close to the information, but they're not very conscientious,
Right.
and another that are far from the information, but are very conscientious, maybe it's an even thing. But the advantage should always be to the people who are closest
So how do
to the
people know that,
practice.
Mitch? How do you?
Well,
actually say-
the start, which again, we're all working on, is that whenever I see a patient, I give them my card. The number on the card is directly to the people who answer the phone for adult medicine 2 at Gouverneur.
Right.
And that's their best shot.
Right.
But it could be that the phone doesn't get answered. Right, and that's part of what we've been working on these last 5 years, is being sure that the phone gets answered.
Yes.
The call center then works because, of course, you might call that number at 3 a.m. There's nobody there.
But if it's
But
not
then it would
answered,
roll.
Mitch, does it roll to
Yes.
the,
Yes.
even during the day?
Yes,
Even the-
if as he was explaining, the call will first look for a member of the staff
Right.
to answer. But if there's not, and that could be for a very good reason. The nurse is on the phone with someone else, right? There's one, right? Because again, when you talk about a local response,
Right.
then that means there's one nurse there, right? And maybe one receptionist. So if they're both on the phone, it's got to roll to someone or it's not going to get answered.
So
Do-
people
do we
calling,
have-
sorry.
If I could just run through these, do we have a breakdown on the type of calls that come in? Are they more to make an appointment? Are they more to find the lab hours? Do we have there are 2.6 million calls, so I don't expect you to have them all, but,
Find your doctor, like I be looking for my doctor. So that's so great. This is great.
it would be helpful because it's
Yeah.
useful to know, as Mitch
It is.
says, if you're further away from him and you're just calling in for an appointment, and it's not a doctor like Mitch who gives you his number,
Yeah, see?
then it's helpful to know, and
That's
we'll
right.
find these. What percentage of those calls come in? How quickly are they answered?
Mhm.
How many of them are answered by our staff versus external staff? I think the more
Data.
data we have, the better you're able to assess the efficiency of the service, but also whether it makes sense to do more of the service or more of our own in-house staff. And those are a lot of questions. I don't expect to have them all.
And they're good questions. They're very
they're
good questions.
And I'll say that one of the things that we've done in the last year or two is work very hard to improve the level of data that we have. Right? We look at how many calls were answered in how much time every day. And every month every week we meet with the vendor and we talk about like how quickly the calls were answered.
The vendor or our own staff?
The vendor to like how quickly they because we have like how many calls were answered within 20 seconds,
Right.
how many calls were answered within 30 seconds, so that we know that people are picking up the phone
Right.
to get the calls. As far as what the breakdown of the calls is, like what are people calling about?
Right.
We've made a lot of changes to help better parse out that information, right? Like so we can better track it and keep a handle on it, right? Like what happens when an agent finishes a call, they disposition it so we can keep track of that. We keep track of like what feedback we're hearing. One of the other things that that Optum will bring to the table is when the call is done, they'll do a survey with the patient that will give us an insight into how satisfied they were and how much effort it was for them to complete that call, which will A, help us better understand the kind of experience people are having, and B, help us identify ways to reduce the amount of work that it takes for a patient to call in. Did you call
And-
I'm as concerned about our
Oh,
own
right.
in-house calls, and maybe even more so because you have KPIs, you've got 7 years of experience, which you may or may not carry a lot of into with Change Health. And since they're the first line of defense, our own staff, I am curious to have more data on what comes in there and what gets handled there.
Sally,
think
how
this-
should we do that? I was just thinking, I'm sorry to me,
No, no.
but I mean, I started us
Yeah.
on this, so I'm not blaming you.
No,
I raised it
don't
myself.
expect the answers.
Right. Well, and I know you don't, but on the other hand, I don't want to just leave it out there. So we
Right,
need
right,
we
good.
need some way, right? This is a presentation of a contract which we appear to all agree that under all circumstances there will be overflow and nights, and we need a contract in place. So what I'm wondering is, how would we schedule the other? And probably it would be at MMPA, not here,
Right.
I think, right? I mean, I think that's the closest, to, so
We haven't
we
had
could
a
schedule that.
presentation on the
So that's what I'm thinking is, and I'm looking at Dr. Allen to help us to track it, that we would make a presentation specific to how we handle calls. And I agree,
Good.
it's very important, right? And
Very
if you
important.
don't answer the telephone,
Right.
right, then you're not really
And
functioning.
I think that'll dovetail into what you requested, Mitch, which is how do we then transition? First, we gotta know how we're doing on our own.
Yeah.
And how do they interact with our contractor, our vendor?
Right.
And then how do we transition away?
So let's
I'll
agree to
just
do that.
quickly have one recommendation as well on the AI piece, which I think is going to be a work in progress. You don't have the list of the questions or what we can readily use technology to address and not have calls. You might want to speak to Metro Plus. They just changed their call process so that if you ask for a membership card, if you ask for your PCP's phone number, that's all automated. And I don't remember the company they used, but I think 30% sounds like an aggressive target for AI, but I don't know what it'll be. I don't know what you'll be asking for, because yeah. So that's just a suggestion. You might want to see
Good, good.
what their pitfalls were and
Doctor, that's good.
how they're doing.
That's good.
Okay, I won't ask any more questions.
Thank you, Sally. I think one thing on the discussion we're having that might be interesting, because Optum has all these technology features and capabilities, is as you're thinking about, because I realize that some of this is still under negotiation and discussion, is as you're building out the KPIs that they're tracking, is to put some of this, I don't know if, for example, your customer survey afterwards, is that only when it gets to an Optum agent, or is it start from the beginning of the call and tracks all the way through, or can there be a survey when it doesn't actually go to Optum, that kind of thing, so.
I can't speak 100% because we haven't really walked through what that is going to look like. But
Right.
typically, in my experience, the call would have had to terminate on their side for us to get that survey, because the survey happens after they're done talking. So they would, because they don't own the telephony for our internal team, we're not on their platform, we wouldn't get that. But what we would get is if they call 2 or 3 times, typically Optum will do the research on every single call to figure out
Why they called.
why they called so many times and why they had to call different.
Yeah.
So indirectly, yes, and it's certainly on our end top of mind to try to make the experience as seamless as possible, whether they reach the vendor or an internal person.
Right.
And so,
I mean, just thinking like sometimes when you speak to someone and it's an internal person, not a call center, and they say, I'm gonna transfer you for a survey if you're willing to stay on the line, that kind of thing. Like, I don't know if Optum
we can ask that.
do that, and
That's
then
possible.
you can start tracking that data using that contract. So,
Yeah.
but I don't know if that's part of what they offer. So.
Yeah, I mean, we can ask. I don't know how often people will manually do the transfer, but we can certainly see if that's available.
Yeah.
Were they the lowest cost? Were they the lowest cost as well as?
They were not the lowest cost, but they certainly had the most. They scored the highest in almost every other category, and they were the most secure, which weighed very heavily for us. Like, the security team, from a technology perspective, felt the most comfortable with their responses. Candidly, the fact that we get to retain some of the tribal knowledge of the previous vendor and yet still have the robust structure of Optum was weighed heavily.
On that point, I think in the RFP discussion, you said you anticipated having additional costs to support the transition, but then I think because we selected Optum, maybe we can avoid some of those costs. Is that
Right, additional costs for implementation.
Right.
So that because transitioning to a new vendor requires all kinds of technology changes and platform changes, and so at the time we anticipated that we'd have to pull additional resources in to execute all of that change. And with Optum, we'll be retaining a lot of our same technological resources. There will be some changes, good changes, right, like the CSAT surveys and their telephony, but the net resources that we'll need internally from our EITS team will be much less compared to other vendors.
So that's helpful on the cost front, at least,
Right.
for transition. One other thing, on the cost is increasing, obviously, from the prior contract. But we, and as is everything, as we're going to hear about from the finance team, but the AI tech capabilities, I think, I see you guys have anticipated initial goal of 30%. I have no idea whether that's achievable or not achievable, but based on industry standard being potentially higher, if you are able to achieve better technological improvements, can you anticipate the not to exceed, or not the amount of the contract to go down? Is that?
Absolutely. I mean, any calls that we can deflect using AI will significantly reduce our per minute cost because that AI process is cheaper, right, per minute, and the calls will be shorter. And any exploration we can do around self-service options, I kind of like what you mentioned with MetroPlus, like self-schedulers or anything that, where people can get hours or get information without having to like wait online and talk to a person will help reduce our cost. And we're very focused on finding ways to do that.
Great. Sally, any other questions? Jackie, any questions?
No, I just enjoyed the discussion because I think that's one of the reasons that motivated me to get on this board is sitting on the phone forever waiting for for the machine to pass me here. This is so good. I'm
Thanks.
glad we're working on
So
it.
it sounds like a follow-up will be good for
Yes,
everybody.
yes.
All right, well, if no other questions, we'll take a vote. Dr. Katz?
Yes.
Sally?
Yes.
Jackie?
Yes.
And I vote yes, so the resolution has been approved to go to the full board. Thank you very much. Next on the agenda is a financial update from the finance team, so I'll turn it over to John.
Nice
Thanks.
to see everybody. Yeah, we have quite a few slides here, and I think about 45 minutes left. But I don't see this being a problem to kind of get through most of this information. We'll start off and just go through how we closed out the year. Talk a little bit about that. We have a couple slides on FY24 development, just to give you an update of kind of where we're at in that process, and then we have a couple of slides just updating you on the financing related to HERC. May, right, we finished $679 million in the bank, about 27 days, which was was right on the mark for us. James will talk a little bit about the close and some of the things we had to do there, but I think we finished fairly well in terms of the overall June closeout. We are seeing a negative budget variance of $200 million or 1.4% as of the April close. We'll talk in more detail about that, but it's basically the same drivers, which we will be addressing as we put together the 24 budget. Direct patient care, right, continues to be solid, still producing year-to-year results. The risk pools are really doing very, very well for us. I think about $190 million over budget. Patient care volume is back even stronger than it was before COVID. Outpatient up 8% compared to FY20, and I think inpatient is about returned to where we were prior to COVID. Our overall financial initiatives, right, that basically cut across all the major aspects of health and hospitals continues to perform, very well. Our target was 675. We're at 655. Most of those initiatives are, in the green or yellow stage as we track those. Next slide, in terms of 23, 24, do you want to do this, James, or want me to go?
Go ahead.
Yeah, so we estimated a close in June of approximately $700 million. I think we did better than that, maybe closer to 740, 745. Yeah, 745. So we did okay at the end. We do a special thanks because this is probably one of the more tumultuous closeouts. They're always, we call it the checkbook, right? It's a lot of moving pieces at the very end. James and team do a really phenomenal job at it. But this year, we had those UPL transactions from FY23 that had to go through the entire pipeline of the state and CMS and then the health plans and a lot of transactions. And it got down to really the last 2 days of the year where the monies did come through from MetroPlus and Health First. So it was a little bit of a wild ride towards the end. But we did fine. We had a backup plan to that. So again, I think it's it's very nice to see our health plan, partner with us when, we're trying to get something done
So James slept all last week.
and James is doing just
Because
fine.
he didn't sleep the week before.
Well, and John always has a backup plan to the backup plan to the backup plan. Right.
Thank
Right.
God.
Yeah, right.
There was a, in case of emergency break
Right,
glass
right,
button
right.
too, right?
It's always, he always has a backup plan.
Right. So yeah, I think a pretty good close overall, for us, as good as could have been expected, I think. So with that, Salima?
Sure, I'll walk through the next couple of slides. These should be familiar to everyone. As John stated at the top of the slide deck, we have a $200 million, 1.4% negative variance as of April. It's driven by the fact that our receipts came in over budget by $350 million, but it's offset by the fact that our disbursements came in also above budget to the tune of $550 million. The drivers, if we go to the next slide. On the revenue side, big ticket item is risk pool came in 187 million higher than target, largely due to higher than anticipated PMPM in Medicaid. We also have our inpatient outpatient rates that came in higher than we assumed in the budget to the tune of 144 million, and that includes 87 million of unanticipated appeals that came in. And then we have a small variance in other revenue, mostly driven by miscellaneous.
Sorry, go ahead.
Next slide, on the expense side, we have our overspending trend is continuing, largely driven by temp staffing coverage, 325 million over the budget target there. Other discretionary spend is also over target of about almost 200 million. It's driven by medical and non-medical supplies and pharmaceuticals. And lastly, we have our affiliation spending coming in at 30 million above target, largely driven by the use of sessionals and locums. This last slide is just a year-over-year view of how we performed on the revenue and inpatient and outpatient specifically. You can see that our direct patient care revenue, when you exclude T2 and testing, is 3 million lower than prior year. It's largely driven by the timing of our UPL conversion coming in on the inpatient side. Compared to the same period last year, discharges are up 3.2%, visits are up 5%. And the CMI is slightly lower by 2%.
Hi, I'm Margie Carlin. I'll take us through. We have a couple of slides talking about Medicaid recertification. We've actually shared these plans before, but thought it was important to reiterate as the recertification has started, so these plans have now been activated. They were a little theoretical when we last brought them forward. And also, the success will really have significant implications for our overall budget performance. So we are implementing strategies on our own, along with in coordination with MetroPlus and Health First. We have multi-channel communications to patients, flyers, signage on our websites, as well as MyChart messaging going out. We are doing outreach to patients. Both local and centralized financial counseling teams are reaching out to patients to remind them of their recertification and to step them through those processes as needed. And we're leveraging all of our patient interactions at the point of scheduling, the clinical interactions, registration interactions, community health workers. It's apparent on the Epic screens that each of these clinicians and other staff see that a patient does need to be recertified with their plan and have the appropriate referrals in place to sort of walk them through who to talk to. I'm going to turn this over to Allison Hartman, who will walk us through how we're tracking this and some, up-to-the-minute numbers on how we're doing.
Good morning, everyone. As Margie mentioned, just wanted to share a view into how we'll be tracking the efficacy of all of the strategies that we've now implemented in order to achieve our end goal of helping our patients maintain coverage whenever possible throughout this recertification period. We've developed multiple views that will be tracking our results, including some internal tracking, as well as visibility into tracking from Metro Plus, Health First. What you see on this slide is just a summary view into Metro Plus's dashboard, tracking some of the very, very early results for the first cohort of members who came due for recertification last month. So these statistics are really as of the close of June. We expect that they will continue to catch up and mature as individuals do still have the ability to recertify through the close of the month following their recertification end date. But did want to share, and actually I'm talking about the wrong slide. My apologies. So this is actually, oh, okay. So, you know, we're looking at these early results for that month of June, and you can see there's actually some differences that, you know, we're still trying to glean some of the patterns in these numbers, but seeing better success recertifying individuals who have an established CAC, who's an individual who helped enroll that individual into the health plan. Some challenges in particular with the age, blind, and disabled population who have to recertify through our local Department of Social Services, which is listed as HRA here. But continuing to work through some of these challenges and just very closely watch these early results and hopefully watch these numbers continue to continue to creep up, as well as, you know, continue to make progress in the future months. If you want to advance to the next slide, this is our internal tracking within H&H. We're tracking both some process metrics so that we can track our activities assisting our patients in real time, as well as some of those outcome metrics, focusing on, in particular, our attributed membership and tracking that membership against some of our assumptions in our financial plan. As Margie mentioned, there's really significant financial implications for us staying as on track as possible, but our financial plan does assume a decline by about 24% in attributed membership by the end of FY24. So we're hoping to track that closely and hopefully, if possible, stay on track or do a little bit better than those numbers. You can see an example here of what our internal tracker looks like, tracking both, as I mentioned, our activities, so recertification trackers created. That's the activity of our internal H&H financial counselors assisting patients with re-enrollments, as well as those outcomes looking at our recertification rate across our two big health plans, Metro Plus and Health First, as well as just what that means in terms of attributed membership, churn, which is really the month-to-month change in membership, including individuals switching between lines of business, and what that results in terms of our resulting payer mix. What % of our patients remain enrolled in Medicaid or Medicaid managed care? As I mentioned, still very early numbers, but Metro Plus, as of the last report, at about 62% recertification for the June cohort. And we do have some very early numbers from Health First, tracking in the same ballpark, perhaps just a few percentage points lower than Metro Plus, but again, do expect those numbers to creep up a little bit.
And we're doing the same kind of outreach for the Health First as we are for the Metro Plus.
Yes, we really are trying to maintain consistent outreach regardless of the members plan, including the fee-for-service population.
And when's the deadline for all these, for this? I mean, how much time do we have to get to 76%, I guess?
Really about a year. So individuals will continue to come due for recertification month over month based on when they originally enrolled in Medicaid. So through the end of the fiscal year, about June 24.
June of 24, okay.
But I just want to be clear, recertification is an ongoing process. It was halted during the pandemic. So we have a population of patients who became Medicaid eligible during the pandemic. They maybe never had to recertify before, as well as a cohort of financial counselors who started working during the pandemic and never had to go through a recertification. So we're educating both on how to maintain this, but certification even after the year ends will continue. This is just a backlog. We have more members on the rolls who became eligible during the pandemic and didn't have to recertify.
Right.
And Margie, generally, this is in terms of lost dollars, isn't it mostly a problem when people don't need services, right? To the extent that they come forward for services, you're going to be able to enroll them generally. But you're gonna lose on the capitated
Is that right?
hugely because the hardest group to incentivize, right, are the people who don't need anything, right? They're, the largest group are young men, right? They don't have a reason, they don't need a women's clinic appointment, they're going around living their life, they fall off the rolls. How do they know? They're not getting any bills for anything, but it affects, the total
Ours.
enrollment in the plan, and therefore what we get as part of I mean, I don't want to put words in your mouth. That's how I understand the
I would
problem.
agree
Would
that
you
that's,
agree?
I agree that's probably the biggest risk. We have, the recertification strategies that I went over, and I really did touch the highlights, both Metro Plus and Health First and Health in Hospitals and the state are all doing outreach to those populations. So we are trying to reach out to populations who are on our rosters who haven't necessarily had services. We also have ongoing work, and I might be stealing somebody's thunder, to bring people in for services who haven't had services. So there's an ongoing work effort there. But certainly, if somebody is scheduled for services or comes in for service, it's just another touch point that we have to be able to walk them through the recertification process, sure. So there's definitely a
Right.
bigger risk.
And when you're doing that, then it's easier to explain, right, to them, right? I need to
Why it's important.
recertify you so that you can get the health care you need, including getting whatever prescriptions your doctor orders today, right? I mean, it's a lot
Absolutely.
clearer, to the person at that moment,
Right.
right? Than, imagine you're calling, a healthy, 28-year-old male, and you're trying to convince him that it's really important that he submit his documentation
Right.
for his Medicaid so that his health care is covered, and he's like, why are you calling me? I'm fine.
Right.
Right. It's just it's a harder one. And he may have originally gotten on the program because he had an accident, right? He had a bad sore throat, he went forward, he got covered, but now he's like, why are you bothering me? But obviously the financial implications are huge for us.
Yeah.
I just have a couple of questions on what you've done already before we get too far along. On your financial performance, the unbudgeted Medicare and Medicaid appeals, those are appeals that were completed, were successful, and generated 84 million for us?
Sorry, yeah, so we don't budget for appeals typically. We align with what's in the financial plan, and we did get some, mostly Medicare appeals from various cost reports, reallocations and things that came in from prior years.
And on you had 325 million for temporary staffing, and the other discretionary spend was 195 million. Is there a big category in that, or it's lots of small categories?
Right, so the biggest category in the discretionary is pharmaceutical and followed by med-surg supplies.
I guess I wonder about pharmaceutical, because we just approved a contract, right? And we have a big pharmaceutical company that we get our medicine from. Are these,
Cardinal one?
yeah, are these different?
Cardinal. So it's largely driven by inflation, but also increased utilization of pharmaceuticals because of the increased volume.
And I don't think we're much different, Sally, than pretty much any other healthcare system. I mean, there are some that are seeing 15% increases,
Right.
just inflationary pressure. We're not that high, but we're definitely, and that will be recurring, right? That'll be like a recurring expense. The others, the patient care, the temp nurses, the locums, right? Our plan going into '24 is to do the best job we can to shed those
Right,
higher
right.
costs. But the inflation, unfortunately, I think is going to get left behind. But we are working and refreshing our contracts, with the contractors and expecting better deals on the supply chain.
And your decline in Metro Plus Health membership by 24%, what does that translate into in dollars?
So in the budget.
You're talking about the Medicaid recertification.
Yeah.
Well, we assumed in the budget a loss in our risk pool. To Dr. Katz's point, a lot of those low utilizers were driving up our excess medical revenue. And so for Metro Plus, we do assume a loss of about $100 million in risk pool compared to what we achieved for calendar year '22.
100 million is the assumption for the '24 budget, is that?
That's just Metro Plus.
For Metro Plus.
Oh, just
You'd have a separate one for
Health First.
Health First.
Yes, Health First is a bit smaller, and again, there's a lot of things that hit the risk pool for Health First, so it's a little harder to dissect. But the loss on Metro Plus is about $8 million.
On Health First?
I'm sorry, Health First,
8 million?
in the budget, yes. And that's because it's based on cash. There's a lot of things that come into the risk pool, not just excess medical revenue. So
Right.
it's not really apples to apples.
And they're also more Medicare,
Yeah,
while Health First is more Medicaid.
So the longer it takes for the recertification process, the worse this problem gets, is that kind of, because we're expecting 74% the fiscal year has begun and we're only at 62, right? Is that?
Right, I think 62 is really just the beginning point, right? When we talk to, the experts at the state, who's got I think a very good perspective on what's going around statewide, I think we fall within the ballpark of what's going on.
Their
And they
words
gave
were,
us
it's good.
And they gave us another month, right? Didn't they extend the period another month? So the state's gonna try to do whatever it is that they can do, right, to try to promote, right? I think they're, I think most states, or some states can't say that, that's their intent. Our state certainly is doing whatever they can.
Pushing for 80%.
Yeah.
That's what the goal is. by
Yeah,
the end of June.
And I would say that the assumptions that Salima is using pretty much mirrors the same assumptions that Health First and Metro Plus are using. And everybody's gonna try to beat those numbers, but I think we are trying to align with them, and as we will track with them in terms of, how the research's going and how the risk pools, and then the risk pools have a lag, right? So we're always on a lag with them too, which on the receiving side, there's a lag, so.
right, so the full impact of the loss we won't see because we are collecting in fiscal year '24, we'll be collecting for calendar year '23. So the recertification period for 6 months, we still have solid revenue for that period.
And just one last question. On your growing your premium revenue, you included diagnosis capture on members with social needs. Is that thinking about social determinants of health?
Yes, and we can talk a little bit more about that. That's gonna work its way into coding, and CMS is really starting to press on that, which we think is a good thing for us, as well as Metro Plus and Health First.
I think this gets to the next section a little bit of what we're.
I'm sorry.
No, that's okay, Sally. So are your questions on, okay. So why don't you guys go ahead? Yeah.
Hi, I'm Megan Maher from the managed care team. So I'm going to walk you through the next couple of slides. So at a very high level for this new fiscal year, there are 3 large value-based payment priorities. And the first, as we've just been talking about, is growing and retaining our value-based payment membership. So of all of the work, this is really mission critical to make sure that our members are maintaining their Medicaid coverage. We are also doing a lot of work to try to optimize our managed care enrollment to make sure that we're pairing our members with primary care physicians who have the best schedule access so that if patients are newly auto-assigned or auto-enrolled to health and hospitals, that we can get them in for an appointment and establish health and hospitals as their medical home. We're also doing a lot of work on growing the premium revenue that's attached to each of those members in our value-based contracts. So as Margie alluded to, really trying to expand outreach to disengaged patients to try to figure out if they haven't been in to have their mammogram in the last several years, or they have chronic care prescriptions that are going unfilled, really trying to outreach to them and engage them to come in for care. We are also doing a lot of work collaborating with Revenue Cycle to try to understand the accurate diagnosis capture on those polychronic members as they're coming in for care. And this is where they may also have social needs that we want to make sure that we're documenting, to really be able to reflect to the health plan of the members that we are attributed. This is the full complexity or acuity of those members, and then we will in time get enhanced premium revenue to reflect that. So we deliver good care. We know that we see very complex patients. We want to make sure that the revenue that's tied to them is accurately reflecting their complexity. We're also really prioritizing patient satisfaction. And so there's lots of work in terms of really looking at CAHPS scores, which are surveys done of patients, to make sure that they have access, that they're getting into care, and that we're trying to align our contact center and our primary care doctors to members so that everyone can get the best type of care we can possibly provide.
Yeah, that's why the performance metrics and things under the contact center contract are very important.
Yes, yes.
And getting them more to our in-house, closer to the service.
Right. And then third pillar for fiscal year 24 is to improve the quality and efficiency of our care delivery. So we have clinical teams that are working to scale best practices for patients with asthma or congestive heart failure. We are trying to assess the quantitative and qualitative impact of our ongoing care management programs, and also really trying to figure out how our post-acute teams really factor into the quality of care that our value-based members are receiving. So those are all work streams that will continue throughout this fiscal year. Next slide. I'm pleased to report that we recently received our calendar year 2022 Health First VBP quality results, and we did exceptionally well. All but one of our measures improved over calendar year 2021. And when we look at the top facilities in the Health First provider network, on the Medicaid side, we had, I think, six, thank you, 6 of the top 10. And Medicare is very noticeable. We had 3 of the top 5. So that was a really exciting achievement. And
3 of the top 4.
3 in the, yeah, let's keep going.
Yeah.
2 in the top 3. But so commensurate with that is we have additional quality dollars that we earned for calendar year 22. So all of that is moving in the right direction and is
Terrific.
a result of really trying to invest in outreach that we're doing to patients to engage them in their care as best we can.
And being able to share all of this amongst our different facilities so we can take all 10 of the top 10 spots.
Exactly. One day, yeah. And then what are we watching for? So we're breaking down positives, risks or negatives, and unknowns. So on the positive side, we were awaiting implementation. Well, we are currently awaiting implementation of the state budget that was passed in I think late April. That we believe will increase the essential plan premiums, which will be positive for our premium revenue, and our managed care quality pools were restored. And so that's important as we're investing in our quality infrastructure to make sure we can get compensated for that. We are also awaiting approval of New York State's Medicaid 1115 waiver, which is looking to invest in social service supports and is going to be really important for our system. So those are all positive things that should be bringing in more revenue to the system. On the negative side, or things that we're watching for, our biggest Medicare VBP contract is with Health First, and we know that their 2024 premium revenues are going to decline because they lost 4 stars. They went down for 2024, and so that will be a loss of premium revenue in our risk pool. We also know kind of the double whammy is that also in 2024, Medicare is going to be adjusting its risk adjustment methodology to better look at ICD-10 coding. That happened many years ago, but risk adjustment takes a little bit of time to catch up. So the new model we know is going to be eliminating about 2,000 diagnosis codes that disproportionately impact vascular disease, major depression, and angina conditions. And we are expecting that that is also going to reduce the per member premium amounts that Health and Hospitals receives in its risk contract. So those are two negative financial pressures in our Medicare risk contract that we'll be watching.
What's the impact of the loss of the star on premium revenue? Do you know?
To Health First as a whole, John,
Or
I
to
don't know.
us?
It was 200 million.
For them as a whole?
Yeah.
But and for us?
For us, we're about a quarter of their risk pool. I don't know if we're the quarter of their, from a dollars perspective. I know from a size perspective, we're about a quarter, but it's sizable. So I would say in the tens of millions of dollars.
And we went up, what, half a star, while Health First lost the star.
Right.
But we're all in it together, and I'll say I think Health First is very committed to getting the 4-star status back. I mean, I think we all share the fact that we're, a provider-run health plan, and we should excel, in the star scoring. And back to the point of access and the importance of the contact center, I think those are one of the areas that New York City in general just struggles with, is that sort of ongoing relationship with the patient. The CAP scores is very important. But there's a complete commitment on everybody at Health First that we will do what we can to try to get the 4-star status back.
So we can help them.
We can definitely help. Yeah, we can definitely help.
And then finally, we've talked a lot about this morning, but the unknown is really how the Medicaid recertification will fare this fiscal year. And hopefully we're outperforming our targets and retaining some more premium revenue. Great, thank you.
Thank you. Just on the ICD-10 coding, that's something that will affect everyone, right? So,
That's correct.
That's done, or there's any effort that this might change?
I think that it is being implemented for calendar year 2024. I think the work ahead is to try to figure out, really laser focus on how are we diagnosing those conditions that they're downweighting some conditions, but there might be more dollars for other diagnoses. And so it's a matter of us really trying to, at the end of the day, be as accurate as possible in the diagnoses that we're choosing and how we're documenting our encounters, and hope that, by doing that diligently, we'll be able to continue to enhance our risk premium.
Medicare constantly has to redo it, in part because doctors tend to upcode depending upon what they give more money to. So at periods of time, CMS looks and says, oh, it seems like now
People are
all
diagnosing
being
this.
diagnosed with major depression instead of moderate depression. Okay, well, if that percentage is increasing, then maybe that group isn't as sick as it used to be. And so, we should lower the amount of dollars. It's not necessarily unfair. Doctors have historically been shown to, we are a fully salaried model, where people are not earning based on what they're coding. But most of American medicine is for profit. What you earn from Medicare depends on what you code.
But this is in a value-based system.
There's still need, because think about it, while it's value-based, it can't and shouldn't assume that if I'm doing a good job, it would cost the same for me to take care of a healthy 25-year-old man as a 70-year-old man with vascular disease. So the idea of a true value-based payment is you make an assumption about what would be a good cost based on the underlying characteristics that I can then meet or do better than. But everyone can't be the same cost, because no matter how well you manage the 70-year-old person with multiple diseases, they'd have to cost more.
Right.
So value basis still requires that you have fairly sophisticated coding to try to give a sense. And that's also why we've been pushing that the social determinants need to be part of coding. Right, because whether or not somebody is homeless is going to greatly caused higher costs in caring for them, but traditionally it's always been ICD-10 codes, which are all diagnostic codes. You have this kind of vascular disease, you had that kind of heart attack, you have diabetes. It's always disease-based as opposed to social state-based.
And so where is that stand in?
We're making progress. I think more and more people understand that it's happening. But it's still not like, you get this amount if you have this kind of vascular disease and that amount if you have that kind of vascular disease.
But our coding contract that we have, is that for 23? These don't get included? Or?
So when you say the coding contract, you mean the audit,
Yes.
So it's underway now. So the coding reviews are underway. They started with, I think they're all through the first round of reviews, and they're doing some report outs at this point. We don't actually have the data yet. But they are looking at, the DRG coding, they're looking at ICD-10 coding and ensuring each piece of the puzzle is there. So there'll be more on that. I think over the next month, there will be report outs from the actual reviews.
All right, thank you. FY24.
Yeah, we can give you a little preview, right? And we'll come back to this as that we finalize the entire package. And we are making, I think, great progress there. So James, you want to just start on the first line, and then I can.
Sure. So in terms of FY24, just a reminder for the executive plan that we put out back in May, we're projecting a $184 million loss in fiscal 24. Now that's largely due to the things we've talked about, today in terms of temp costs and affiliation costs being above our previously anticipated number, even as we hope and expect the glide path during the year to bring that down as we get into FY25. As we look at other cost pressures as well, we have inflation and pharmaceutical costs, as Salima noted. And then we should also note that in fiscal year 24, we do have the assumption of the start of the federal dish cuts, which are slated to begin October 1 of 2023. We are hopeful that they will get delayed or repealed again, the delay as it has a few times before. Things are working their way through Congress. There has been a bill that's not just the dish cuts as a standalone, but does have a 2-year delay again. It did go through the House Energy and Commerce Committee in May, so we're following that closely, and we're hopeful that we can get that.
And what's the FY24 dollar amount for the dish cuts?
So the FY24 dollar amount of the dish cut federally would be about $8 billion, and we estimate that would be about $600 million to us. Now, some of our financial plan does assume actions we would take to mitigate that, so it's not a one-for-one dollar improvement. I mean, it would be some actions that we would adjust, but the size of the cut is over $600 million.
The Majority Leader Schumer has said that it will not happen.
It won't go into effect. It'll be
That
delayed
he
again.
will succeed in getting it delayed.
So that continues to be our hope, but our assumption in the plan, as it has been since they were first proposed, is that it's there for now. But that would be a improvement to us if they indeed get delayed, as we hope they will. And then just noted down here, as with 23, we did start the year with a proposed deficit and had one during the preliminary plan as well. So we're hoping to do, many different actions, whether it's, the implementation of the things that were included in the state budget, the risk pool collections, beating the target, as we've talked about, recertification or other just strategic initiatives to try and get back to balance, as we did with FY23.
Ultimately, we have to be in balance. We don't really have
A choice.
We don't have a choice, so we will be in balance. But as James says, it's perfectly fine for this point in the development of the budget that we don't yet know how we will get in balance. but this is a
There's a lot of
manageable
unknowns,
amount.
too.
There are a lot of moving parts. As the year progresses, we will make whatever necessary adjustments, but one way or another, we will not be in deficit. We will close the year even.
Yes, yeah, so I think, you know, and as part of our process, you know, James and his folks kind of do their independent, you know, estimates of where they think overall spending is going and the size of the gap. Micheline and Selima do their own independent work. They have a 3-phase budget process that they walk through with the CFOs and the CEOs. We're concluded the second phase of that. And we do know that the gap, it might be even a little bit higher than $185 million by the time we're done. But we do have a plan starting to come, you know, into shape. And it's our hope over the next couple of weeks here that we'll have a plan that we've all agreed to with the facilities to close the gap. One element of that is that we've assigned to the facilities a gap closing estimate or target. It'll be about $75 to $100 million across the system. I think the target values are around 1% of total operating expense, maybe a little over 2 at one facility. So we think that they're manageable targets. We've given them, you know, the flexibility to decide how they want to achieve the target, and we expect those to be coming back to us tomorrow, right? Or tonight? Today. Yeah, today's the deadline. So we'll see what comes in. But what we've done here, and there's been, you know, plenty of a conversation, but what we've done is and they will come up with a good plan. I mean, they will come up with a better plan than if we came up with the idea, right? Because theirs is going to be tailored on where they see spending reduction opportunities. Plus, also we're encouraging, you know, revenue growth opportunities as well, expanding, you know, service lines and the like. But what we did provide to them is various themes that they could, you know, refer to as they're developing their plan, and we've kind of, you know, bulleted those out here. You know, improved quality and financial performance in value-based care, right? We went through, you know, most of these, and there are opportunities, you know, across the board. We think, right, as we get, you know, more focused on value-based care and the systems that we need to develop to even get better. And we note that the CAP scores down there are going to be important to us. You know, we'll continue to get better at the basics. You know, we've had a meeting on accounts receivable performance. I think there's a recognition that, you know, we can do better in AR to get closer to industry standard, and we've had a couple of conversations with the facilities about, you know, where we see opportunity for them there. We've talked about, you know, pharmacy and setting costs and renegotiating supply chain contracts. The locums and outside temp costs, we know that's the problem, right? So we got to stay focused on solving that problem. And Selima, is part of the budget development for '24, has, I think, a pretty reasonable, what we call glide path to get from where we are today with our dependence on locums and subcontract staff, and then over the course of the year, phase those staff out while we're hiring and training our own replacement staff. So that will be you know, we have a model for that. We're going to be explaining that to the CFOs tomorrow. It will be something that we track at our monthly meetings with the CEOs. It's very important that we stay, you know, very disciplined on the shedding of temp staff.
That, something that they can control, though, if it's,
Yeah.
I mean, you know, we can set a path or a target.
Yeah.
If it's not available or we can't hire
Yeah.
people.
I think all of that is true, right? And that's, you know, that has been, you know, the conundrum that we've been in, is, you know, trying to make sure that we're appropriately recognizing and adhering to the ratios that we've committed to. And at the same time, we have, you know, and in some cases, we're even over those ratios, right? So we look at that in terms of, you know, why is that? But my sense is that the locum contract market is starting to reduce. and I think that the market has a big effect here. Obviously, if we, as part of our NISNA negotiations, we're very hopeful that we conclude those negotiations as soon as we can, and paying our nurses a fair wage compared to the market. We think that will also, have an effect. But, our commitment is to staff the bed. Now, if we find out that we can't get a handle on this, then you're faced with more difficult, decisions about can you continue to provide that care. But our preference is not to have to go there, obviously. And you'll see here in the next one where we talk about systemness, is there an opportunity for us to actually, move business lines strategically across the system, right? Where maybe, it makes sense to provide, one level of tertiary care at a tertiary care hospital and all the services that are, a component of that, and maybe shift some of the other services to another local facility where perhaps they can provide it more cost effectively. So all of those things are in play, but yeah, we'll have to be disciplined as we enter the year on keeping an eye on the outside temp costs. It is significantly.
One thing which will not be in play is providing services poorly. Right, that's one of the, well, you laugh, but and I don't fault anyone, but 5.5 years ago, the solution to the budget crisis was to hold positions. When you hold positions when they become vacant, then the hole is wherever the person left. And since people don't leave randomly or evenly, you ran services that were inadequately staffed. Right, because the focus was on whatever the person left, you just held that, right? And my commitment is I believe very much in the success of public service healthcare, and if we have to constrain what we provide, we will, because we have to live in a budget, but we won't provide services poorly. If push comes to shove, then we have to look at, okay, maybe we can't provide this service over here, or maybe we can't provide the service at all. But what we won't do is provide the service in a poor manner. I don't believe in that. I see no valor in maintaining services that you cannot provide well.
Yeah, no, it's an excellent point, Mitch. And I think, we were one of, I think, the first, big healthcare systems to, endorse the staffing ratios. And we like that approach, right? Because it allows us, we translate that right directly to their budgets. So we know that at least there's enough resources at the bedside, right, to provide the care. And our goal, again, throughout '24 is to expand that sort of staffing analysis where we have more ratios for, varying different types of employees. So, and we will build that, into the budget and keep updating, as the census goes up and down. But we like that budgeting approach, and again, obviously Mitch has always been very clear with us that we're not gonna, reduce the resources needed to provide good quality care. So.
Thank you.
So I talked about systemness. We have a big capital plan. We're revisiting the plan to make sure that, the capital priorities are lined up with, solid performance on our operating budget side. Multi-year plan, right? I talked about this, increased pharmacy supply costs, the 1115 waiver we talked about. And then we have some more ongoing work going on with CMS and the state on UPLs and trying to align that for the future. So that is our plan. We'll come back with more details.
Sally, go ahead.
The affiliate increases, what is causing that? I thought we had.
Yeah, so the affiliate increases, it is one of the faster growing line items. I think it was 12%, something like that. I mean, it's obviously one of the pressures that we're trying to manage, but we have seen an increase in locums, the number of locums, the cost of locums. We've seen big increases in sessional usage. So for the first time, we actually have data that comes to us from the affiliate at the department level, and we can see year-to-year increases in sessional hours. Now, an increase in sessional hours isn't necessarily a bad thing, right? Because if you have a vacancy, right, a doctor may be willing to pick up extra shifts, right? That makes sense. Or you may have had a surge in, volume of services, or people are taking badly needed vacation. There are a bunch of reasons why you can't just read the number and say that's a bad thing, but there is, again, we've given this data to the CFOs last week. We've asked them to take a look at that as they're developing their budget targets to see if in fact the sessional use is this workforce plan that allows us to look at the entire affiliate budget, and we've defined how many doctors that we need at any particular facility, right? Allows us to have a lot of different discussions about not only the need for the appropriate mix of providers, but conversations around our business lines, but for us, holding the affiliate accountable for filling the jobs that we've asked them to fill.
Just to add, so it's all personnel, right? I mean, we don't buy equipment, so from them. So everything is the actual person. And we're always involved in what they pay. So it's not like we could say, well, they're paying too much, because we determine, if they wanted to pay too much, we would say no. And we have the full ability to say no. The problem is that because so many physicians have left the workforce, there's just been a lot of inflationary pressure. And to some extent, what happens when we don't fill the positions is then we use locums or we use sessional. And part of what John is talking about, which is, the same issue of, we can't just underpay the physicians because they won't work. They just won't come. And we see that in areas. We just don't have them. Then we have to distinguish those things that we could live without. Okay, so we're not going to have a rheumatologist at this facility. If you need rheumatology, you're going to go to that facility, or you're going to wait longer. On the other hand, at a trauma center, I have to have, and this is what John means about ratios, I have to have a certain number of anesthesiologists. It's not a choice. It's not a choice, and you can't run the trauma center without them. And so then you're very subject to the inflationary pressure because you got to have them. And so if you don't put the salary, so you either raise the salary, okay, so that causes an inflationary pressure. Or if you don't raise the salary enough, you wind up with more sessional and more locums, and that causes a different kind of inflationary pressure. And sometimes that inflationary pressure is worse than if you raise the salaries. So it's something you constantly have to watch, and it also isn't even. In the most recent time, it's been the anesthesiologists and the radiologists who have most driven the inflationary pool. Probably because, unlike, say, other kinds of doctors, they don't have an established patient pool, right? They can move around, right? There's no continuity needed by your anesthesiologist. So, right, if primary care doctors are lowest paid, I think, because we're so attached to our patients, it's hard to get us to move, right? But the anesthesiologists, they have no problem. They're done with you. You're done. Next patient. Someone else will pay you more to take care of the same patient. You move. And once you get into true shortages, it's very hard to avoid the inflationary pressure. So it's going to be very challenging. The physician, nurse, other technologists, we lost a large number in COVID. And not just us. And none of this is unique to us.
So is this, to your point on, we're not going to sacrifice care, so we may need to look at how we're balancing what we offer. And I think, John, you referred to the systemness nature, and can we do what we need to do by balancing it out? Is that something that we're looking at?
Yes. Yes, and you could. It could affect wait times for non-time sensitive services. Right, I mean, that's one, I mean, that's what happens in the real world when you can't fill a position, right? The wait time gets longer for whatever service, right? And the safety valve is always the ED in the hospital, right? I mean, for good and for bad, right? If your condition is getting worse because you cannot see the X specialist, you're going to wind up in the ED. Where then we do have, if you will, we're paying for the specialist there, right? So let's say ENT is a good example. Almost all outpatient ear, nose, and throat is not urgent. How many ENTs? There's no ratio of how many ENT doctors a system like Health and Hospitals must have. You know, common diagnoses: sinusitis, chronic ear infections, sleep apnea. But if you have an acute ENT problem, say you have a nosebleed that won't stop, right, and there's no availability in the outpatient, the safety valve is that you're going to wind up in the emergency room where they will be able to call the ENT, because the trauma centers all have to have ENTs on call as part of the staffing. So people will never go without. In an ideal world, you'd always care for people in the most timely way, in the most appropriate setting. In the real world, you do your best. But in a bad world, you have the appointment, but you don't have the people to serve the people.
Right.
Right. And then you're pretending that you're providing the service when you're really not. And that's what I don't like. I think you have to be honest.
Right.
We are the best funded public health system in the country.
That's right.
Right. We have a $10 billion budget. Right. We have to do our best, recognizing that our best will not meet everybody's needs in the most timely way, in the best setting possible. And we don't do that now. I don't know any public system that does that, right?
But we're trying to balance a lot of things, right?
Yes.
With improving your care, your, what is it, caps?
Yep,
and-
access, yep.
Right, and things like that.
Right.
Trying to balance the
So you
inflation.
watch all of the things, and you try to figure out which of the services that have the highest impact, and make sure that you provide those. Those services that have lower impact, you may have to go, or again, you figure out more efficient ways, like the telestroke is an excellent example, right? Where you're paying one person to be on call, who can then see a variety of patients, because they're not, I'm sorry, you weren't here, we had a presentation on telestroke, where a neurologist can see the images on his or her phone, and therefore can serve the needs of patients at multiple hospitals. And now we credential people at multiple hospitals specifically so that they can do it. That is a much more efficient way than paying for a neurologist to be at each hospital, which we at the moment cannot afford. So sometimes through technology, through common sense, right, you figure out how to make things better.
There's a lot with this one for sure. But I think we feel pretty good, right? I think we have a plan. We have we call it, workforce plan at each one of our hospitals. We're trying to look further into the future about our needs for the supply of, physicians and providers. And we also starting to take, many of our future physicians are with us today, right? We have one of the largest teaching programs in the country, right? So many of them, hopefully, right, will stay with us, into the future. But having competitive salaries, obviously, something very important.
Yeah. So when's our next finance committee meeting? September?
I don't know. Next one.
Not till October. It would be good to maybe try to get an interim
Yes,
update, even if
it'd be
it's
good.
not in finance committee.
We would like that
just-
too. Yeah, I think we need about 3 weeks to finalize the budget, right? To finalize kind of how the budget's gonna shape up. But
Okay.
yeah.
Yeah, that,
Yep.
because a lot moving, a lot of,
Definitely.
things that could swing different ways.
Could swing different ways.
Yeah, so, okay, great. I think there's one more section on the update.
Perk, yes.
And I'm Bailey Jones, and I've got Dr. Ted Long joining us today in case there are programmatic questions about either of our initiatives. So quickly first, our test and treat financial update. T2 has committed approximately $10.1 million in expenses for Q4 of FY23. OMB continues to provide us with sufficient revenue to cover those expenses. And as we updated you last time, we've ended all of our programming as of May 11th, given the end of the federal emergency. COVID-19 testing, treatment, and vaccination continues to be available at all NYC Health and Hospitals locations. You can see our FY23 breakdown there, and our total expenses for the year. Any questions there? Okay. And then our HERC financial update, our latest emergency program. On October 7th, Mayor Adams announced a state of emergency and assigned H&H to oversee HERC program. HERC sites provide the following services: basic human necessities such as food, clothing, and shelter, resettlement with transportation to friends or family in New York City or beyond, and medical and social services. And there are currently 12 H&H operated HERC sites open. Again, OMB has a similar agreement with H&H to provide us with revenue sufficient to cover these expenses associated with the program. And you can see here the executive budget that was laid out, the amount of committed funding for each fiscal year over the next 3 years to H&H.
Thank you. Sally, any
I have
questions?
no questions.
No. Ted, thanks for coming.
So the best questions I've had all day. So.
I have just one quick question on the,
Yeah.
on the HERC sites. So we have 12 open. I know we're not the only ones managing the HERC sites, right? How does that happen? Like, how do we get involved or not get involved? As the
So
case may be?
we've designated the HERC sites sort of defined as our ability to offer the types of services that are unique to asylum seekers. We developed the model. We developed a model for adults. We developed a model for families with children that need other things. I mean, these children are largely unvaccinated for things like MMR, varicella, need to be enrolled in school. So we figured out how to solve all of those issues for people coming into New York City. And in developing that model, we've then sought to apply that model in larger sites. So we've had larger hotels, things like that, we've been successful being able to build out for asylum seekers. Once we developed the model, once we created the larger hotels, and once we also decided to take on the Arrival Center, which has been
That's one of the 12?
the
Or that's
Arrival
addition?
Center is it's actually in the same building as one of the 12 in the Roosevelt Hotel, but it is akin to Ellis Island. It's the single place where all asylum seekers are coming into the first place they go to when they come into New York City across the board. So it's been a very active part of our overall scheme, if you will. And when we did that too, there was an opportunity. The HPD volunteered to take on one of the HERCs. So we have all of the HERCs except for one. HPD we work very closely with, and they're using our model that we really developed and honed after helping thousands of people with it. And they offered to help to expand our overall citywide capacity.
So really, up to now, it's been us for the most part.
From the HERC side, yes, we to date have all but one of the HERCs.
Right.
Is the Roosevelt Hotel being used for housing as well as a welcome center?
It is. So the hotel is broken up into two different parts, and that's where I just came from. So in the hotel itself, it's 1,000 beds, and it's the beds are 90% of them approximately are exclusively for families with children. So if you go to that part of the hotel, you see all the children running around who are being enrolled in school, vaccinated, brought into a better life. The other part of the hotel, which is really sort of, I guess, where the main entrance was, is the Arrival Center. So there's a demarcation. The Arrival Center itself is where you come in. We have ask everybody the same unified set of questions. screen you for communicable diseases, help to figure out what your plans are, how we can help you to complete your journey, maybe even that same day, which we've been actually, I would say, very successful with. But before the arrival center, people coming into New York City, some came into Port Authority, some came into the airports, people were going to different places. There wasn't one sort of streamlined process for it. We didn't have the same questions we were asking everybody, so we couldn't answer data questions, even like who's arrived recently, things like that. So we've combined all of that into the Roosevelt Hotel, so it is a bustling place to visit.
Your new TNT.
Yeah.
Ted, is this
I have a
staffing?
question.
Oh, sorry.
That's right.
Yeah.
What's the ages for the kids? Maybe I missed that. I don't know.
So for families with children, and that's the criteria for staying at a place like the Roosevelt Hotel, you have to have at least one child less than 18.
Yeah, I'm sorry. You have to have one child.
Less than 18.
Oh, okay.
Yep. So typically we're seeing, a lot of 6, 7, 8-year-olds. When they come in, we vaccinate them, we enroll them in school. If you're over 12, we screen you for depression and connect you to care. So we're doing a lot.
Okay.
Two follow-ups, Ted, on that. So the staffing of, say, the arrival center, and are we staffing that with H&H personnel? Is that a contract or?
Yeah, so the way that we're staffing, I'll say, operating the arrival center and the HERCs is at any of our sites, we have an H&H person designated that's in charge of that site. They report up to Sarah Joseph Curry and Chris Keeley, me. So we have line of sight, and there's always somebody from H&H that's responsible for all of our sites. That was when Mitch and I first went into this, we said, that's very important to us as H&H. If we're going to own this, we want to make sure, as Mitch said earlier, we're operating with the highest quality care. That is how we want to orchestrate this. Beyond that, we then have vendors that solve different staffing needs, basically. So we have frontline staff, 90% of which are bilingual. That's one vendor there. We have a vendor that does security. That's a different vendor. We have a vendor that does food, a different vendor.
Great. And what about medical care? Are we providing medical care at the sites?
We are. So at all of our HERCs, we have 24/7 medical care, and that's true of the arrival center, which is the definition of a New York City all 24/7 operation. Because we have a lot of families that come in overnight with kids. It's really interesting to see this. They make it here at all hours of the day. When they arrive at the arrival center, we have a medical team that screens you for communicable disease, like I said. Medical team that will talk to you about any chronic diseases that you need to have addressed right away and any mental health issues, and we do the PHQ screen for everybody. If you have any positive there, you go up to the second floor. We have medical teams. They'll be able to deal with whatever the urgent needs are and then connect you into health and hospitals for further care. At our other HERC sites, we have 24/7 teams that are there for urgent or emergent situations. We even are leveraging virtual express care on site for people that have urgent needs that can be dealt with through telehealth. And then beyond that, we're seeking to connect everybody into New York City Health and Hospitals primary care.
So on the financial side, just to ask, what goes under the MOU and what is H&H budget on medical staff or medical care?
All expenses are covered by the MOU.
So even if we have H&H doctors, for example, on staff at the arrival center, then that would be
Anything that
allocated.
we're incurring on behalf of the city for this program is covered by the MOU.
I think where you're going with this, one distinction, which is an interesting opportunity, is when people are connected to care in our system, then they become just our patients.
Yeah.
And one cool thing about that is that we've enrolled through the help of Metro Plus more than 12,000 asylum seekers at our sites alone with health
Into Metro
insurance.
Plus.
Metro Plus and so a little bit to some other I think insurers too, but
Terrific.
predominantly to Metro Plus. But that's 12,000 people that when they came to the country didn't have health insurance. Now they do. And then there's NYC Care on top of that.
Right. That's wonderful.
Are those medical personnel that would otherwise be working in our hospitals or folks that we've hired? Great.
These are folks that we've hired that are overseen. The medical director of the HERC program is Dr. Jonathan Jimenez. So they're overseen by Health and Hospitals. So we oversee every part of the operation from the nuts and bolts of frontline staff to the medical components, but the services are actually delivered by additional staff that bolster the capacity that we need to take care of this population.
Great.
It's great. I think I heard someone said about the medical insurance. Do everyone have the same asylum seeker that came in, do all of them have the same medical insurance?
So it's actually a really interesting question. I honestly, I've learned a lot here. So asylum seekers crossing the border into our country receive documentation putting them predominantly on parole status. That makes you eligible in New York, and finance colleagues, please jump in here, for plans like the Essential Plan. And then that's how Metro Plus and other enrollers are able to enroll them in health insurance plans. It's not exclusive to one plan, but we have the Essential Plan as one of the options, if you will, for how people, based on their the status that they have when they cross the border with the documentation they have that defines their eligibility. Anything, finance team, you guys want to add to
So
that?
the Essential Plan has a very favorable premium. So, yes, we welcome enrollment in the Essential Plan.
We're all for it.
Is that the good answer?
And I asked that because I did get, I was concerned because I heard conversation, as they say in the street, and people talking, they said, so we don't have the same, everybody don't have the same medical health insurance plan. So this is why I asked. And what constitute, I know you sort of kind of explained it, but what constitutes that? I mean, what is the distinction? What's the difference?
Yeah, so one of the, I'll make a little bit light of it for a second because this is part of the politics involved in it. Whenever you see the terminology illegal or undocumented, that's not applying to the what people intend to refer to as asylum seekers.
Okay.
They are here on parole status and they have documentation of their parole status, so they're not undocumented. That documentation makes them eligible for a variety of things, including in New York State, the Essential Plan. And we've done it 12,000 times now. So I think that's 12,000 lives we've saved or changed, based on the ability to connect them to health insurance, so healthcare not just in our system but beyond in New York City too.
Terrific. Thank you. Any other questions? Well, thank you very much. It's a very robust report and a lot to talk about. We appreciate all the work you guys are doing. I know there's lots of ups and downs here. So, and I think that's what we've got. Any old business? Any new business? There being no further discussion, meeting adjourned. Thank you. Thank you. Thanks for coming.